afternoon, my student. Today we begin new lecture about pathology of endocrine system. You know that all periphery endocrine glands, thyroid, adrenal, pancreas, sexual, parathyroid, are closely connected with each other as well as with the central endocrine glands. Pituitary, epiphysis, right neuronal hypothalamus. Besides connection of the endocrine system with immune system, thymus in particular has been proved. Therefore, it is more correct to speak about neuroimmunoendocrine regulation of the human organism homeostasis. It is necessary to remember about the systems of cells called Apud system, which produce biogenic monoamines. It is known that when one endocrine gland is involved by a disease, dysfunction occurs in the other. If several glands are damaged, the state is called polyglandular endocrine pathology. Also, classification of endocrine pathology. All diseases of endocrine system are divided into congenital and developed. They may be represented by hypofunction, hyperfunction, dysfunction. It is case dystrophy, atrophy, dysplasia, sclerosis, and tumors may develop. A practical classification of endocrine pathology is based on the damage of the main primary gland. The most frequent are endocrinopathology of pituitary body, adrenal glands, thyroid gland, pancreas, parathyroid gland, sexual glands. Also, disease of pituitary body. There are acromegaly, gigantism, Itsenko-Cushing disease, hypophysialnism, cerebral hypophysialcachy, diabetes insipidus, tumors. In this slide, we demonstrate histological signs normal structure of pituitary gland. The normal microscopic appearance of the pituitary gland is shown here. The adenohypophysis is the right and the neurohypophysis is the left. Also, disease of pituitary body. The diseases of hypophysis are connected with the affection the front part, adenohypophysis, and the rear part, neurohypophysis, and is displayed with the change of the purple hormone secretion. Besides, the affection of the adenohypophysis is accompanied by the local change, the growth of the size, which can be detected by means of the X-rays or computer examination. It is also displayed by malfunction of the signs because of the optic second cranial nervous pinching, the increases of the intracranial pressure, which is accompanied by headaches, sickness, vomiting, etc. The malfunction of the hypophysis appear in the case of tumors, autoimmune, inflammatory, and necrotic affection or affection of hypothalamus or nervous system. The most widespread diseases of the hypophysis are hyperpituitarism and hypopituitarism. The hyperpituitarism often appear in the case of adenomas of adenohypophysis, which are almost always hormone active and secrete one or another hormones. Also, in this microscopic picture you can see signs of microadenoma. This microadenoma of the anterior pituitary. Microadenoma of anterior pituitary. Such microadenomas may appear in 1 or 5 to 5% of adults. These microadenoma really have a significant hormonal output that leads to clinical disease. Acromegaly and gigantism usually develop in eosinophilic cell tumors, adenocarcinoma of pituitary anterior lobe. The somatotropic adenoma or adenocarcinoma produce the progress of acromegaly for adults and gigantism for children. Excess of somatotropic hormone stimulated all mesenchymal derivatives, bones, cartilage, connective tissue. If the disease occurs at a young age, it is called gigantism. If at an older age, it is called acromegaly. The bones does not grow, but its nose, lower jaw, feet, and hands enlarged. The other glands are also involved by the process. Goiter, thymus, and epiphysis, hyperplasia, adrenal cortex hyperplasia, atrophy of insulin apparatus, of pancreas, sexual gland atrophy occur. Next disease by injury of hypophysis is Itsenko-Cushing disease. Occur in adenomas from basophilic cells of anterior lobe of pituitary or adenocarcinoma in rare cases. Increased adenocorticotropic hormone production causes cortex hyperplasia as well as increased production of glucocorticoids. It results in obesity of face and body, elevation of arterial pressure, diabetes mellitus, sexual gland dysfunction, osteoporosis, nephrolithiasis, and chronic pyelonephritis may also develop. The disease should be differentiated from Itsenko-Cushing syndrome. Its clinical manifestations are the same as in the disease, obesity of the upper part of the body, but the other signs are not clearly marked. The syndrome is characterized by adrenal damage, tumor of zona fasciculata, which causes increased production of glucocorticoids. The next pathology of hypophysis is pituitary nanism. The disease appears in the case of hypoplasia of the hypophysis or its destruction during the period of childhood by the inflammatory process or the necrotic one. The hypopituitarism appears in the case of craniopharyngioma and glioma. The patients of prepubescent period have the pituitary nanism. It is displayed by the general hyperplasia of the organism. In this case, adults have the hypogonadism, the absence lack of the secondary sexual characteristic. Women have the amenorrhea, the atrophy of the external genitals, the sterility, the decrease or degradation of the activity of thyroid gland and the adrenals. In this picture, we demonstrate histological signs of adenohypophysis by hypopituitarism. This medium and high power microscopic waves of the anterior pituitary demonstrate mononuclear inflammatory cells infiltrates with loss of actin and interstitial fibrosis. This feature of lymphatic lymphocytes, a rare autoimmune disorder, but a significant case for hypopituitarism. Next disease is Simon's disease, or other name cerebrohypophyseal cachexia. The cerebrohypophysis cachexia is determined by the progress of the dystrophic and necrotic change in the hypophysis, which is observed in the case of its tuberculosis, atherosclerotic, thromboembolic, syphilitic, and tumorous affection of the hypophysis vessels. Sometimes young women have this disease after the childbirth, with which are accompanied by considerable uterine bleeding, the embolism by the amniotic fluid. It is accompanied by the progressive cachexia, inner organ atrophy, sexual dysfunction. Next pathology of hypophysis is diabetes insipidus. Is this disease caused by tumors, inflammation, sclerosis, trauma of the posterior lobe of pituitary. It manifests itself by increased urine excretion due to deficiency of antidiuretic hormone. Pathology of adrenal gland. You know that adrenal gland consists of cortex and medullary substance. There are three zones in the cortex: glomerular zones, which produce mineralocorticoids, for example, aldosterone; zona fasciculata, which produce glucocorticoids; reticular zone, which produce sexual hormones. The adrenal medulla is derived embryologically from neuronal crest and ectoderm, and is a part of sympathetic nervous system. Its synthesis and secretion vasoactive amines, adrenaline and noradrenaline, epinephrine and norepinephrine. Disease of adrenal glands are divided into the affection of the cortex substance and the cerebral ones, and accompanied by hyper or hypofunction of the proper hormones. Hyperfunction of the cortex substance, or hyperadrenalism, is often found on the base of the pituitary, Cushing pathophilism, Cushing syndrome, the hyperaldosteronemia, the adrenogenital syndrome. The hyperfunction of the cortex substance, hyperadrenalism, the hyperadrenocorticism, the pituitary Cushing pathophilism, Cushing syndrome, appears on the base of increased secretion of the adrenocorticotropic hormone, adenoma of the hypophysis, adenoma or hyperplasia of the cortex substance of the adrenal because of the prolonged glucocorticoid therapy. The hyperfunction of the cortex substance or hyperadrenalism appear on the base of adenomas, the aldosteroma, the idiopathic hyperplasia of the adrenals. It can be primary, initial, and secondary. The disease is accompanied by hypokalemia, the hypernatremia, the arterial hypertension. It is displayed by the muscle asthenia, the impaired cardiac function, the cardiac decompensation, cardiac insufficiency because of the hypokalemia, myopathy, and the myocardial dystrophy, the paresthesia, the convulsion. Hyperfunction of the cortex substance or hyperadrenalism, the adrenogenital syndromes, congenital hyperplasia of the adrenals, is displayed by the malfunction of the steroid hormone synthesis and the accumulation of the androgenic hormones, which provoke the progress of the viricidism. In this picture, demonstrate different change in adrenal gland by pathology. The pair of adrenals in the center are normal. Those at the top come from patients with adrenal atrophy, with either Addison disease or long-term corticosteroid therapy. The adrenals at the bottom represent bilateral cortical hyperplasia. It is called due to pituitary adenoma secretion, adrenocorticotropin, Cushing disease, or Cushing syndrome from ectopic adrenocorticotropin hormone production, or idiopathic adrenal hyperplasia. Also, this is normal structure, this is atrophy of adrenal gland, and this is tumor of adrenal gland, adenoma. Hypofunction of the cortex substance, the hypoadrenocorticism, the hypoadrenalism, can be primary initially or secondary in the case of the adrenocorticotropic hormone shortage. Acute, the adrenal crisis, and chronic adrenocortical insufficiency. Bronze disease, bronze skin, melasma, suprarenal, or Addison's disease. This histological picture presents morphological signs in adrenal gland where develop Addison's disease. Year ago and still today in place with a high incidence of active tuberculosis. The most common causes for Addison's disease was granulomatous inflammation and adrenal cortex destruction. Infection such as histoplasmosis can produce similar finding. Note the caseous necrosis, the glands, pyrogoid cells, and resident cortex in here. Primary acute hypofunction of the cortex substance develops on the base of street, the chronic hypoadrenalism, the sudden quick stoppage token, steroidal agents, considerable extravasation hemorrhagia into the adrenal during the period of the bacterial infection, the meningococcus, the diphtheria, the septicemia, accompanied by the progress of the Waterhouse-Friderichsen syndrome among late children. In this picture, macroscopically signs of Waterhouse-Friderichsen syndrome. These adrenals have a black-red color from extensive hemorrhagia in a patient with meningococcemia and disseminated intravascular coagulopathy. This is known as Waterhouse-Friderichsen syndrome. Infection with necessary meningitis can start initially as a mild pharyngitis but become a florid septicemia within hours. This is histological signs of Waterhouse-Friderichsen syndrome. This is microscopic appearance of the adrenal cortex with the Waterhouse-Friderichsen syndrome from meningococcemia, necessary meningitis infection. There is marked hemorrhagic necrosis of the adrenal cortex that leads to acute adrenal insufficiency. The primary chronic cortex substance insufficiency. Chronic adrenal cortex insufficiency or bronze disease or bronze skin, melasma, suprarenal, Addison disease. This is synonyms of one disease. Develops in the case of the autoimmune adrenalitis, tuberculosis, and metastatic affection of adrenals. The patient have the general asthenia, the fatigability, the weight loss, the hypotonia, the hyperpigmentation of skin, the meloderma, and mucous tunics, the atrophy of the myocardium. Secondary chronic cortex substance insufficiency develops in the case of the adrenocorticotropic hormone shortage. It is often found on the base of tumors, the inflammation, the infection, the extravasation hemorrhagia, exposure to radiation of the hypothalamus or hypophysis, prolonging glucocorticoid therapy. The atrophy of the cortex substance takes place, but the cerebral substance almost doesn't change. Next pathology of adrenal gland with injury of medulla substance, pheochromocytoma, is found among the disease of the cortex substance more often. It is accompanied by the increased synthesis of the catecholamines and high blood pressure. The tumor is found among women more often. It is one side, its color is red-gray or brown, is built of polymorphous cells with light cytoplasm. The malignant variant of the tumor might exist. It proves metastasis into the lymph nodes, the liver, the lung, and bones. In this histological picture, you can see signs of pheochromocytoma. There is some residual adrenal cortex tissue at the low center right with the dark cells of the pheochromocytomas in above and to the left. In this histological picture, pheochromocytoma microscopically, pheochromocytoma is composed of large cells that are pink to mauve and arranged in nests with capillaries in between. Remember, 10% when you think of the pheochromocytoma, 10% are bilateral, 10% are in children, 10% are malignant. Pathology of thyroid gland. Disease of thyroid gland are divided into goitres, thyroiditis, and tumors. They can be accompanied by hyperthyroidism, the thyrotoxicosis, or the hypothyroidism, the myxedema. Goiter, or other name struma, is the growth of the thyroid gland. The base of this process is the hyperplasia. In this case, the function of the gland can be increased, decreased, or not changed at all. According to the morphological science, goitres are divided into diffuse, nodular, diffusely, nodular, mixed ones. According to their histological structure, they are divided into colloid goitres and parenchymatous ones. Also, goitre or struma can be a colloid goiter, looks like a solid dense nodule which is built of the follicles of different size. Usually they are defiled with the colloid. If the follicles are big, cyst-like with a flattened out epithelium, it is a macrofollicular colloid goiter. If the follicles are small, it is a microfollicular goiter. If the follicles have the growth of the epithelium in the shape of the papillae, it is a proliferative colloid goiter. If there are follicles of different size at the same time, it is macrofollicular goiter. And the parenchymatous goiter looks like a fleshy tissue. Its color is a gray-pink. It is characterized by the proliferation of the follicular epithelium in the form of solid structures. The colloid in the follicles is almost absent. This is microscopically signs of macrofollicular colloid goiter. The follicles are irregular enlargement with flattened epithelium, coincident with inactive in this microscopic appearance at low power of multinodular goiter. The early phases of the diffuse, non-toxic goiter leading up to this point may have resulted from either endemic goiter, seen in parts of the world where dietary deficiency of iodine may occur, or the uncommon, non-endemic, or sporadic goiter young adult women are most often affected. Inborn errors of thyroid hormone by synthesis leading to goiter are extremely uncommon. Also, diffuse, non-toxic or simple goitre can be endemic and sporadic. During the first hyperplastic stage of the disease, the hyperplasia of the gland develops. Its weight increased to 100-150 grams. During the histological examination analysis, little follicles are found which are coated with prismatic epithelium. They contain very little colloid. After the progress of the euthyroid state, the proliferation of the follicle's epithelium stops. After that stage of the colloid involved develops. Gradually, the follicles grow in the size and the epithelium atrophy. The weight of the gland grows rapidly. The gland becomes dense, dilating-like in the incisors. It is a colloid goiter which can compress, squeeze internal organs and even provoke the asphyxia. This is macroscopically a picture of multinodular goitre. This diffusely enlarged thyroid gland is somewhat nodular gland weight more than 30 grams. This patient was euthyroid but not increased fullness to the neck. This represented the most common cause for an enlargement thyroid gland. The endemic goiter is found in the region where there is lack of iodine that determines the decrease of the synthesis of thyroid gland hormones because of the compensatory hypertrophy of the gland. Gradually, the hypoadrenalism develops. Adults have the myxedem. The children have the endemic cretinism, which is displayed by the physical and mental gap. The sporadic goiter is found very seldom. It appears among the young women and is accompanied by the euthyroid state or the hypothyroidism. The reason of the disease is unknown. The diffuse toxic goiter, Graves' disease, appears among the young women and is accompanied by the hyperthyroidism. One of the reasons for the diseases is autoimmunization, the appearance of the antibodies which stimulated the cellular receptors of the thyroidocytes. This is genetic inclination for this disease progress. Among the clinical displays of the disease, there are the growth of the thyroid gland, tachycardia, weight loss, increased nervous insensibility. In the case of the Graves' diseases, the typical visceral and local change develop in the thyroid gland. Also, morphological change by diffuse toxic goiter or Graves' disease. They are next, or following. The organ grows diffusely. It has a soft consistency. The prismatic epithelium of the follicles transforms into cylindrical one. There is a proliferation of the epithelium. The pseudopapillae appear. There is vascularization and rarefication of the colloid. There is a lymphoplasmacytic insipidus of the struma. The lymphatic follicles form. This is histological signs of Graves' disease. A diffusely enlarged thyroid gland associated with hyperthyroidism knows the prominent involvement of the hyperplastic epithelium. In this autoimmune disease, the action of thyroid-stimulating immunoglobulins, pseudo-nominated over that of the thyroid growth immunoglobulins, thyroglobulins. This is high magnification by Graves' disease, the tall columnar thyroid epithelium with the lines of the hyperplastic involving into the colloid. Note the clear vacuoles in the colloid next to the epithelium, where the increased activity of the epithelium to produce increased thyroid hormone has led to scalloping out of the colloid in the follicle. By diffuse toxic goitre or Graves' disease, the next change in visceral organs, present affection of liver, heart, brain. Change in heart, developed thyrotoxic heart. In the heart, the next change, the hypertrophy and fatty adipose generation of the cardiac histiocytes, the serous edema and myocarditis, which result of diffuse focal or localized myocardiosclerosis. In liver, changed by diffuse toxic goiter. Present edema, present fatty or adipose degeneration, present interstitial inflammation with progress of the fibrosis and formation cirrhosis in the end. In brain, by diffuse toxic goiter or Graves' disease, present dystrophic change in nervous cells, present perivascular infiltration in the medulla, present dystrophy of the cortex of the adrenals is observed too. Patient die because of the cardiovascular collapse, the acute adrenal gland insufficiency during the operations. Next pathology of thyroid glands is hypothyroidism. This disease appears in the case of the thyroiditis, which can be on following types: Hashimoto's thyroiditis, acute granulomatous thyroiditis, the acute lymphocytic thyroiditis, fibrous thyroiditis, purulent thyroiditis. Hashimoto's thyroiditis, or autoimmune or lymphatic struma, often appear among women who have the genetic inclination for this disease. In the pathogenesis, the most important role is played by autoimmune affection of the organ parenchyma. The diffusive lymphoplasmacytic seeping page on the gland with the forming of the lymphoid follicles develops. Because of the influence of the immune cells, the parenchyma dies. It is replaced with the connective tissue. The lymphothyroidism develops afterwards. This is macroscopically signs of Hashimoto's thyroiditis. This symmetrically small thyroid gland demonstrates atrophy. This patient was hypothyroid. Initially, the thyroid is enlarged, and there may be transient hypothyroidism, followed by a euthyroid state, and then hypothyroidism with eventual atrophy later. Hashimoto's thyroiditis results from abnormal T cell activation and subsequent B cell stimulation to secrete a variety of autoantibodies. This is histological signs of Hashimoto's thyroiditis. Note the lymphoid follicles. This is autoimmune disease, and often anti-thyroglobulin and antimicrosomal thyroid peroxidase antibodies can be detected in serum. Other autoimmune diseases such as Addison's disease or pernicious anemia may be also be present. Both thyroid growth immunoglobulins and thyroid-stimulating immunoglobulins are present, though blocking antibodies to immunoglobulins thyroid mitigate the effect. This high magnification by Hashimoto's thyroiditis. View of the thyroid which demonstrates the pink Huttle cells at center and right. Lymphoid follicles is at the left. Hashimoto's thyroiditis initially leads to painless enlargement of the thyroid, followed by atrophy years later. Aside from surgery, this is the most common cause for hypoadrenalism in adults. This is two fluorescent microscopic signs of Hashimoto's thyroiditis. Here is an example of immunofluorescence positive for anti-thyroglobulin antibodies. The acute granulomatous thyroiditis appears among women after the viral infection. The gland grows asymmetrically, gray-yellow infiltrating are found in it. The leukocytic infiltrating with the glandular purulent portion of the gland are observed too. The macrophagous granulomatous with the admixture of giant cells and fibrosis progress appear later. These microscopically signs subacute granulomatous thyroiditis or Acquire's disease. This is probably follows a viral infection and leads to painful enlarging thyroid. This disease is usually self-limited over weeks to months, and the patient returns to a thyroid state. Note the presence of large foreign body giant cells with inflammatory destruction of thyroid follicles. Acute lymphocytic thyroiditis very often has no symptoms. Usually it is found during histological examination of the operating material. The lymphoplasmacytic infiltration are low-coded subcapsularly. The reason for this disease is still unknown. A fibrous thyroiditis or struma or Riedl's thyroiditis is displayed by the hypothyroidism, which appears because of the follicular atrophy and the growth of the fibrous tissue. The organ becomes very dense. The reason for this disease is still unknown. The purulent or infection thyroiditis appears after the secondary hematogenic traumatic infection of the gland. The purulent inflammation and the insignificant decrease of the gland function are also found in this case. Tumors of the thyroid gland can be non-malignant and malignant. Among the non-malignant tumors, the follicular adenoma are found more often. They develop on the base of A and B cells. They are represented by the follicles of different size. The solid adenomas made of C cells, which produce calcitonin, are found too. The tumor is represented by the big light cells with the light cytoplasm. Also, there are papillary adenomas. They have needly papillary accretion extension among the cystose neoplasm. The presence of the papillary accretion is bad signs according to the positivity of the malignization. The secondary change can be found in the tumors, a little extravasation, hemorrhagia, areas of necrosis, sclerosis, and calcareous degeneration. There are atypical adenomas made of fusiform cells. There are also the dermoid cysts, the lipomas, the hemangiomas, the teratoblastomas. This is macroscopically a picture of follicular adenoma. Histologically, that is surrounded by a thin white capsule. It is sometimes difficult to tell a well-differentiated follicular carcinoma from a follicular adenoma. Thus, patients with follicular neoplasm are treated with subtotal thyroidectomy, thus to be one safe side. Is this histological signs of follicular adenoma? Normal but compressed thyroid follicles appear at the low right. The follicular adenoma is at center, follicular adenoma in center, to appear left. This adenoma is well differentiated neoplasm because it closely resembles normal tissue. The follicles of the adenoma contain colloid, but there is greater variability in size than normal. The malignant tumors of the thyroid gland are often found among women. They are represented by the cancer, which can be papillary, follicular, anaplastic, or medullary carcinoma. Malignant tumors of the thyroid gland. The papillary carcinoma is found more often. Clinically, it is displayed by thyrotoxicosis. Macroscopically, it is dense tumor. Its color is gray. It is tumor with petrificates and cysts. Its diameter is 7 to 10 cm. It is built of papillaries with the growth of the cuboidal epithelium. Histologically, the hypochromic empty nucleus without nucleolus with the eosinophilic insufficiency of the cytoplasm. The plasmos corpuscles are located inside the papillary. They are capsulated and follicular variant of the tumor. The tumor provoked metastasis into the jugular or cervical glands. This macroscopically signs papillary carcinoma. This neoplasm can be multifocal, as seen here because of the propensity to invite lymphatics within thyroid, and lymph nodes metastasis are common. The larger mass of cysts can contain papillary extents. These tumors most often arise in middle-aged females. This is microscopically signs of papillary carcinoma. The founds of tissue have these fibrovascular cores. The fronts have a papillary pattern. There is no such thing as a papillary adenoma, and all papillary neoplasms of the thyroid should be considered malignant. The malignant tumor of the thyroid gland, the follicular carcinoma, are found among women. It is represented by the gray or brown pink node with several centimeters in diameter. It has the inclination for the marked infiltrating growth. It grows through the vessels and provokes metastasis into the lung, liver, and bones. Malignant tumors of the thyroid gland continue. The anaplastic carcinoma among the people of the elderly age who live in the regions with a lack of the iodine. It has the marked infiltrating growth and quick metastasis. Its treatment is usually ineffective. The medullary carcinoma appears on the base of the parafollicular cells, C cells. It is accompanied by the increased synthesis of the calcitonin. The tumor is represented by the gray-yellow node with the dense coincidence and amyloid fragments. The squamous cell carcinoma and fibrosarcoma are found very seldom. This is macroscopically signs of anaplastic thyroid carcinoma. This neoplasm is firm and infiltrated surrounding structure, so that externally on the left there is no discriminably thyroid sap. The cut surface on the right reveals areas of necrosis with a cystic change along with the white neoplasm that extends to the margin of resection. This is microscopically signs of anaplastic carcinoma. The anaplastic carcinoma shows here is inbinding into skeletal muscles fibers at the right. This is most aggressive thyroid cancer and luckily the least common. A medullary carcinoma of thyroid gland histological signs. At the center and the right is a medullary carcinoma of thyroid. At the far right is a pink hyaline material with the appearance of amyloid. These neoplasms are derived from the thyroid C cells and therefore have neuroendocrine feature such as secretion of calcitonin. The disease of the parathyroid gland are displayed by the hyper and hypoparathyroidism. The primary hyperparathyroidism appears in the case of the affection of gland by tumors process, the adenoma, the adenocarcinoma, or in the case of its hyperplasia or the autoimmune process. Commonly, the adenomas are the same. They grow as a node on the base of the acidophilic or transitional cells. They are accompanied by the extravasation, hemorrhage, the gamosiderosis, the necrosis, and fibrosis. The disease is also accompanied by the hypercalcemia, the hypophosphatemia, the osteoporosis, the generalized fibrocystis osteoitis, the parathyroid osteodystrophy with the overgrowth of the osteoid tissue, the metastatic tumor, the urolithiasis, the peptic stomach ulcer, the neurological change, the convolution, the worsening of the memory, and the ophthalmological ones, the cataract, the calcification of the cornea. These macroscopically signs of parathyroid carcinoma. The serum calcium can be quite high. No, the large size and irregular cut surface. These carcinomas have a tendency to invade surrounding tissue in the neck, complicated the removal. This is histological signs of parathyroid adenoma. Attention, expansive growth. It is the most common cause for primary hyperparathyroidism. A rim of normal parathyroid tissue admixed with adipose tissue cells is seen compressed to the right and low edge of the adenoma. The disease of the parathyroid gland, the secondary hyperparathyroidism, appears after the erroneous ablation of the gland during the operation. It's the cause of the inactive inborn absence of the glands, autoimmune or hereditary disease. The patient has the hypocalcemia, the increased neuromuscular irritability, the tetany, the laryngospasm, the increase of the calcium concentration in the bones, the cataract, the hypoplasia of the teeth. Disease of endocrine part of pancreas. The disease of endocrine part of the pancreas can be displayed by the increase or decrease of the islet cells function. The decrease of the B cells function is observed more often that determined the progress of the pancreatic insular diabetes. When the tumor adenoma develops the anti-hyperglycemic syndrome appear in the case of the beta-insulinoma. The Sulin-Gellison syndrome multiply endocrine neoplasm with pleural ulcers on the mucous tunic of the stomach in the case of the insulinoma or the gastrinoma. The pancreatic insular diabetes is a chronic disease which appears of insular insufficiency, and it is accompanied by the dysmetabolic dysfunction with affection of vessels and internal organs. Also, diabetes mellitus. The disease is due to relative or absolute insulin insufficiency. This is classified into spontaneous, secondary, diabetes of pregnant, latent or subclinical. Secondary diabetes may occur in pancreatic disease, acromegaly, Itsenko-Cushing disease, complicated genetically the syndromes, and administration of some drugs. Diabetes of pregnant occur during pregnancy. Latent or subclinical diabetes is not evident. Spontaneous diabetes mellitus can be of second type. First type, insulin dependent. Second type, insulin independent. Spontaneous diabetes is an independent disease. Also, the spontaneous diabetes is observed as an independent, self-dependent disease. The pancreatic insular diabetes of the first type often appear during the early years. Juvenile diabetes after the virus infection, the autoimmunization to B cells. The disease progresses with the presence in the inflammatory infiltration numerous T and B lymphocytes macrophages. The pancreatic insular diabetes of the second type develops among the adults. The base of the disease is the insufficiency of the B cells function and the insulin resistance of tissues. Insular insufficiency provokes the dysfunction of the glycogen synthesis, the increase of sugar content in blood, the hyperglycemia, the advent of sugar in urine, the glycosuria, the progress of the hyperlipidemia, the acetonemia, the ketonemia, the acidosis. Macro and microangiopathy develops in vessels, the insular apparatus of the pancreas, kidneys, and the liver becomes damaged. In this picture, you can see histological signs of first type diabetes mellitus. The presence of the lymphocytic infiltration in this adematous islet suggests an autoimmune mechanism for this progress. The destruction of the islet leads to absolute lack of insulin that characterized type 1 diabetes mellitus. Morphological displays of diabetes mellitus. In pancreas, the next change is very important. Please, you must remember. Also, atrophic change, lipomatosis, hyalinosis, and sclerosis. Please, I repeat, change in pancreas by diabetes mellitus. Atrophy change of parenchyma of Iceland, lipomatosis of parenchyma, hyalinosis of parenchyma, and sclerosis of parenchyma. Change in liver by diabetes mellitus. Fatty atrophy, fatty dystrophy, decrease of glycogen contained in the hepatocytes. A change in vessels by diabetes mellitus. Very important complication by this disease. Also, macro and micro angiopathy, which are determined by circulatory immune complex and the products of disbalanced metabolism. In this picture, present histological signs, second type diabetes mellitus. This Iceland of Langerhans demonstrates pink hyalinosis with deposition of amyloid in many of the Iceland cells. This change is common in the Iceland of patients with second type of diabetes mellitus. Also, morphological displays of diabetes mellitus. The diabetic macroangiopathy is characterized by the affection of the elastic and muscular elastic types arteries. It is displayed by progressive atherosclerosis with the progress of vessels necrosis and low extremities gangrene. Diabetic microangiopathy is characterized by the system affection of the arterioles and capillaries of different organs and tissues, the plasmatic tripping and affection of the basal membrane, the dystrophic change, the proliferation of the endothelium and perithelium, the atrophic change of the cells, the inflammatory lymphohistiocytic seepage of the site wall. Morphological change in retina of the eye by diabetes mellitus. The seepage of the site wall develops because of the diabetic retinal microangiopathy. It is displayed by hyaline degeneration and capillary silting, the vein microaneurysm, the perivascular edema, the extravasation hemorrhage, dystrophic and atrophic change of the optic nerve. There are two types of the retinopathy, non-proliferative one or simple diabetic, which provokes separate microaneurysm and dotty extravasation, and proliferative one, which provokes the capillaris neoplasm, considerable extravasation, the retina sclerosis. The sclerosis is the optic nerve papillary, with the progress of the glaucoma, the retina exfoliation, and loss of the sight. Sudden extravasation into the vitreous body are possible with the following progress of the one eye bleedness. Morphological change by diabetes mellitus in nervous system. There are systemic affection of the peripheral nerves, especially in lower extremities, with the following progress of the paresthesia. Affection of temperature, vibratory and pain sensitivity. Sometimes the motor nerves are affected too. The progress of the segment demyelinization, the edema, the axon dystrophy is observed too. Morphological change by diabetes mellitus in kidney. In kidney develops the diabetic intracapillary glomerulonephritis and glomerulosclerosis. There is the proliferation of the mesangium cells in the glomeruli because of the soiling of the mesangium by the metabolic products and immune complex. The hyaline degeneration of the mesangium develops gradually and the destruction of the glomerulus. The fibrin huts appear on the capillary loops of the glomerulus. The glycogenic infiltration, fatty dystrophy, and gidropic ovacuolar degeneration are observed in the epithelium of the nerve segment of the nephron. The epithelium becomes high with a light opaque cytoplasm. High proteinuria, the edema, the arterial hypertension are found clinically. The kidneys decrease in the size symmetrically, the have to the small graining surface and hard consistence. The glomerulosclerosis can be nodular, follicular, or diffuse and mixed diabetic. Also, by diabetes mellitus very often develop next complication. First, diabetic coma. Second, those connected with angiopathy, gangrene of extremities, myocardial infarction, bleediness, and other. Third, diabetic nephropathy, acute and chronic renal failure. Fourth, infection sepsis. The death is caused by coma, diabetic glomerulosclerosis, gangrene. Tumors of endocrine part of the pancreas, or other name insulinomas, can be benign, non-malignant adenomas, and malignant or adenocarcinoma, the low-grade differentiated adenocarcinoma which provide metastasis into the regional glands and the liver. The sclerosis, the hyaline degeneration, the amyloidosis of the struma with the microcalcifications are often found in the tumors. Insuloma is a tumor from 0.5 to 2 cm which consists of B cells. It is located in the body or in the tail of the gland. It is displayed by the state of coma accompanied by the hypoglycemia, high level of the immune reactive insulin, serious neuromental disorders. The fits attacks are often when the intravenous injection of glucose is made. In this picture, we demonstrate histological signs of insulinoma. This is a microscopic appearance of the immunohistochemical stain for insulin in the islet cell adenoma. The alpha cell tumor can reach the size of 10 cm. It is located in the body or in the tail of the gland. It is characterized by increased level of glucose synthesis. It is displayed by the determinate demonstrating the pancreatic insulated diabetes, the anemia, and weight loss. The most obvious change are seen on the skin, the necrotic migratory erythema with the numerous papular vesicles, erosions, and the parts of hyperpigmentation. The patient emaciation, exhaustion develops because of generation catabolytic change in the organism. The gastrinoma develops on the base of G cells. It is displayed by the Zollinger-Ellison syndrome, which appears as a result of gastrin hypersecretion. Numerous ulcers and erosion can appear on the mucous tunic of the stomach and duodenum. They can be followed by such complications as perforation, penetration, bleeding hemorrhages, stenosis, relapses. The tumors is found more often among young men. It reaches 4 cm in diameter and has the structure of the parenchymatous adenoma. It can also degenerate into the cancerous growth. This is histological signs of tumor. The islet cell adenoma. The left contrasts with the normal pancreas with islet at the right. Some these adenomas function. Those that produce insulin may be lead to hypoglycemia. Those that produce gastrin may lead to multiply gastric and duodenal ulceration, Zolin-Ellison syndrome. Carcinoid of the pancreas is displayed by the increased secretion biogenic amines, the serotonin and histamine. The tachycardia, the diarrhea, the bronchial asthma, fits attacks are observed in this case clinically. Thank you very much. Contra